Hi, my name's Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. Many of the significant events in my life involve the person next to me, Dr. Peter Blakemore from Michigan State University, one of my closest and dearest friends. And you'll see various pictures where we're together. And I just wanted to explain, why I'm dressed like I am. And even Peter, is very, very casual. Well, I had a root canal, kind of an emergency root canal this morning. So the whole day has been kind of cockamamie. And then Peter's flight got in late, so we actually didn't have time to change and everything. But Peter, you were there at the beginning of Prolotherapy. You actually knew Dr. Hemmel. So can you just explain our relationship and then how you got to meet Dr. Hemmel and your experience with Prolotherapy?
Yeah, because I guess it's interesting looking back. It somewhat comes as a young teenager for me, coming through. But as I understand it from your interaction with that and all, we had a wonderful self-described little old lady at our church in her mid-80s, Mrs. Florence Wright. And I would periodically take her to doctor's appointments, and that kind of thing, as I was a mid to older teenager there. And so at some point, she had treatment from Dr. Hemmel there at his office on Lake Street. And as I understand, too, I didn't take her to that office. I did actually take her to other offices for other care in the same building there. But that's when she initially told you that you need to have interaction with him. So my interaction came after you had met him, though there had been some interaction from Mrs. Wright, me taking her to other offices there.
Then we started a charity clinic at Harrison Street Bible Church, which you were one of the volunteers.
That would have been 93 or 4, somewhere around there.
And then at some point you worked at Caring Medical.
So I didn't work until 95. It would have been late of 95 or 96 when I started there, because it was after we'd had the start of the Beulah Clinic down in Southern Illinois going there, which was...
So through this church we started a charity work in Alexander County in a very small town called Thebes, Illinois. And that clinic ran from 1994 to 2005. What summer, you spent the whole summer cycling across America?
Yeah, summer of 2000,
Okay, so so we're both in reasonably good shape. I mean, I was a runner and then you were a cyclist. But we had this crazy notion that we were going to then do the Ironman. We decided we were going to do Ironman Coeur d'Alene because we had friends out in Coeur d'Alene. Then we were going to do St. Croix half Ironman because we had friends over there, the Butlers, who have a ministry now in Kissimmee, Florida. And then the people that we stayed with in Spirit Lake, they had a daughter who was single, right? So what happened with that?
Yeah, so from that standpoint, our friends out in Coeur d'Alene, Idaho area, Spirit Lake, a little town near to Coeur d'Alene, had been family friends.
The Pullers.
We'd known in Chicago years before they moved out there. Good close friends of my family. In fact, the Christmas after my dad died back in 95, we went out and spent with their family there. But yes, by that time that we did the preparation for Ironman and the competition, their youngest daughter, Krista, had finished college and was teaching at a college out there in Idaho. And so Krista and I had been family friends through the years, but after the race, we began writing more, and so then subsequently led to us getting engaged and married the next year. It was definitely pivotal for training for and competing in those races that led to my lifelong partner and wife. Yeah, so it's a wonderful thing.
And then obviously you're here to, obviously see old friends, but also to learn, right? Just to see what's going on here.
There's always need for continuing to pushing the envelope of what's possible, and so it's enjoyable to interact with you or others like that and to see new techniques, new ideas.
Here, I just wanted to go through some of the pictures. So the original person who got Ironman,
Dave Scott.
Dave Scott.
So after the race, that's us.
After we finished the Ironman, we got to actually take a picture with Dave Scott, the original Ironman. Then I had written a song, right? I had written a song.
Well,
so that's
the whole musical aspect.
That's Tommy and the Triatones. So Tommy has a good voice, and one of the songs that we recorded was the Prolotherapy song.
Yeah, definitely, which my kids sometimes sing because I've allowed them to listen to it, but it's not necessarily something we want being heard all the time, mostly because of lyrical approaches that the the writer gave to it.
And then we did a world tour with Tommy and the Triatones, right? So that's in the house, the country house.
And the Triatones being 3 monotones singing, which definitely is cacophonous,
Yeah, and then that's where we were recording the Prolotherapy song. We used to compete for our own trophy called the Gauntlet Trophy. Yes.
That day there, I beat Luis because he thought the race was a little bit shorter than it was, so he put his effort in too soon, and it really bugged him. That's the last race we actually ran that I ran with him.
Yeah.
So the poor guy, he does not win, or he does not lose well, and that's his face there is because of that one. Yeah.
And then when we had the 1 mile race, you actually won that one too. So I think you did a 5:08, Tim Kenny did a 5:12, and I did a 5:20. Why don't you explain what these are?
These would be part 3 here from the Ironman, it looks like here. This would be, well, here is a day before Ross and me training out there. These
Coeur
would be my
d'Alene, Idaho.
future in-laws at the time, Doug and Barbara Puller.
After we finished.
Just after the race here. This is a very good photo explanation of proving that Ross and I were the last 2 entering the race on that day for the Ironman, because everybody else is out here in the melee that takes off a mass start, and we just stood there waiting around to make sure.
Well, you did that for me because I was so afraid of the water. I mean, I was so afraid. I still was afraid I might drown it because it was a 2.4-mile swim. Yeah. So you did me the favor of...
Well, either way, it's you may have been afraid of getting your mask kicked off, but I was the poor swimmer at the time anyway. So when the race button went off and everybody jumped the water, we looked like we hadn't even heard it because we just stood around there and waited for it to take off. The only 2 guys of the couple hundred out there. I mean,
couple thousand.
But we both passed everybody, many people ahead of us during even the swim portion. But there's no question we were number 1 and number 2 of the last people.
That's one of my favorite pictures, actually. Just it's just a great picture.
Now, this is an interesting one because this is early on. This is when I was newly coming to work for you here. I'm in the middle there. Back when Dr. Hemwall still had his office next door. Yeah. This is your original waiting room back when it had the Hemwall colors, and so early on there,
the original staff, like one of the first
somewhere around
staffs.
95, 96
there.
Yeah,
95, 96. Yeah. Dr. Hemwall, Mrs. Hemwall.
Back when you still wore like ties to work and everything like that.
I did.
So interesting era.
And then my favorite picture of me is coming out of the water of Coeur d'Alene. That's my favorite athletic picture of me,
you look
because
pretty good.
I knew that once I got out of the water, I absolutely was going to be an Ironman, which, you did just under 13 hours in that Ironman, and I did 14 hours. And then we were,
Because it's great. After I finished, I got to come back and run with you some to finish it off there. It was a lot of fun to do like.
Yeah, you did more than an Ironman because you did the last 3 miles with me. Oh my gosh!
But it was good. It was good to
that was something. Yeah, I remember. Yeah, we're at the Puller's house afterwards, and oh my God, how you felt! Like we're eating potato chips, But no, just love you. Love your family and.
No, it's thoughtful of you too, because it's because of the time getting spent with you that year that I got to do those. Because after that, then going on to medical school and all, I have residents now who just did Ironman this last year, and I essentially get to ride on my laurels. I don't usually go riding or running with them because then they still think that I'm pretty awesome, and sometimes I still think I'm pretty awesome too, until I go riding or running, and then I have facts to give the opposite. But it's because of the time with you that I got to do that. So I appreciate that very much too, as well as the training through medicine.
But with the kids, like you guys got horses, right?
We do.
Like you probably have an active lifestyle, like the kids.
We are very active.
Yeah, explain that, like with the kids.
We live out in the countryside. The kids are very commonly out doing things, or biking, running, and rollerblading outside quite a lot.
Great.
They enjoy swimming. I've gotten to teach them to swim. So you got, I guess, if you will.
Where do they swim at?
Friends who have a pool nearby and things like
Okay.
that. So that's mostly with it. But definitely, they are becoming better than I am, and it's because you made me better by teaching me that too. So it's good from that standpoint. Yeah.
Now you at the university you teach anatomy.
I teach osteopathic manipulation, which has some aspects of the anatomy. They're still using my hands to help fix mostly musculoskeletal problems. So it's applied anatomy from that standpoint, and then have to teach some anatomy in order to do it from the prolotherapy injections and all. I don't think that our residents become awesome and proficient in prolotherapy just to the time because it's only a requirement for them to become exposed to it. I have some that like it a whole lot more, so some have gone on for their conferences and things we get some good training with. But either way, it's a good pushing them and understanding what can be done and all. Yeah.
So for somebody watching this, you're an expert in osteopathic manipulation. I mean, you actually teach at the
Yeah,
medical
that's my board
school, and then
certification,
also you're very proficient at prolotherapy. So when would you decide that somebody needs an adjustment or exercise, and who would need prolotherapy? Like, how do you do it as somebody who's proficient in both?
So if somebody comes with a standard, low back pain type problem like that, the vast majority of patients, the initial visit I'd see them, I would not be doing prolotherapy with them. And that's true like all my other partners. Our clinic is the largest of its type in the world doing manipulation. So we've got a lot of patients, 600 to 700 patients a week getting seen there with that for manipulation. And manipulation is a very good tool to treat acute problems, subacute problems, or manage chronic problems. But I find that if somebody keeps coming back with the same findings and same problem, they do better for a while and they come back. So whether that better is for 3 weeks, 4 weeks, or 6 months, that kind of thing, if they keep coming back for the same thing over and over again, that's an indication of an instability problem, so a ligament laxity type thing. Manipulation can be great for managing that kind of thing, and it's the least invasive. It's easy enough to do that with it. So we have some patients that say, look, I felt great afterwards, and I was good for a month, and then the problem came back again, and so they come back in, and we just keep on tuning them up. But those are the kind of patients that we say, look, I think we can make it so you don't have to see us very much at all or not at all, and that's where we go towards between that and the rest of the physical examination aspect. That's a good aspect of the history, though, where they improve and the problem keeps coming back. That prolotherapy is a good treatment. So those are the ones then that I treat the several times with prolotherapy and then would not need to see them back for the ongoing manipulation. So then sometimes I'll see those kind of patients back a couple years later for a new problem, and they say, oh yeah, that problem I had before, it's gone. That's a wonderful thing to see too, because you have somebody that otherwise you could be seeing them once a month on a regular basis. Oh, you fix them, they go back to life, and then once in a while you see them back for something else. So that's a good indication from there. The other ones would be where manipulation isn't helping at all. So it's either the ones that it's helping but temporarily and it keeps on recurring, or that it's not really helping at all, and the physical examination history all line up to being a ligament or tendon type problem, joint related type thing that we can then go on for prolotherapy or other types of regenerative medicine injections depending on.
Then if you decide you want to do prolotherapy, how do you decide, or what solutions do you use? And I know that you use some PRP.
Yeah.
When do you decide to use PRP versus like dextrose or other solutions that you use?
PRP almost always works better and moves things along faster, but isn't usually indicated enough to warrant for the average person a cost or gives enough benefit. Like, so I find, like, for instance, if PRP would double the cost of the treatment, it doesn't usually make the number of treatments needed for that patient be half.
Oh, you're talking about like a knee.
Yeah,
like
exactly.
A knee
so
problem.
like if it would take, if a standard knee would take, 4 treatments with dextrose, PRP would essentially usually somewhere around double the cost of that, but it wouldn't necessarily make an average knee only need 2 treatments.
It might need 3 treatments.
Exactly. So it still would be. Okay. So I will usually tell patients, say, look, for your kind of case here, PRP would be the better option, but here's all the ramifications. But there are some cases, especially with like meniscus tears, hip shoulder labrums, or really bad cartilage loss, that kind of thing, where I say, look, you're just not going to do as well without going to the PRP. So that's why I'd recommend it right off. Still, I have some patients that we treat with dextrose and they do very well with it, and other people not. The other aspects would be people who just are very poor healers, either because of autoimmune issues. I have some patients who even because of the autoimmune issues will not come off of some other medications that would harm their healing, so like steroids or strong anti-inflammatories, and I try my best to get them off it. But if not, I'd say the best option then is go towards a cellular type treatment like PRP right off, and that's the ones that have done best with it there. So either if it seems like their case warrants it to begin with, I'll recommend it, or tell them I think it's the best option for you, or if they're not improving with a dextrose type approach of the other additives we do the dextrose, we'd go towards the cellular type. I don't do stem cell prolotherapy there at Michigan State right now, primarily just because
like
of the
bone marrow or lipose,
just primarily because of the harvesting aspect with it there. But we do use a lot of PRP.
So when would you say somebody needs to do surgery? There's going to be times where you might recommend a hip replacement or something. Like, what's your criteria?
Yeah, so it depends on the joint. Hip ones especially, if their range of motion is decreased enough to where we just can't get that internal rotation to at least midline straight on, they just don't do well. We can't get improved range of motion ways. Some of those patients still, if they're not candidates for surgery because of other health issues or don't want it, we still would treat. Could often get pain decreased, but the range of motion of that one, especially when that femur just can't get to internal rotation to neutral, It just, they don't do well. Other ones, it may have to do if there are some red flag type things that need to go towards surgery, spinal surgery type things of increasing muscle weakness or bowel bladder dysfunction, that kind of thing from it. Those maybe tend more towards it. But most cases, we're willing to try first and see if we can get them moving well.
Do you, on the first visit of prolotherapy, do you give them how many visits it's going to be? Do you give them an estimate?
I give an estimate based on what I expect from them. It's not a series. I tell them we don't sign up for a series, but here's what I would expect it to be. In some cases, depending on how bad they are, I might tell them I think it's going to be 2 or 3 before you're going to see a huge difference.
Okay.
Also, so you get an idea. But most people, I say, here's the average that I expected for you based on experience and the average patient.
How often do you see them? Like, say you think it's going to be 4 visits for an SI problem or something. Then how often do you see the people? Like once a month?
Usually about once a month, 4 to 6 weeks, depending on my schedule and theirs, depending on what solutions we're using and all like that too. So like the PRP seems to give a little longer healing phase. So if we need to, we can stretch it out a little longer that way sometimes. But for the most part, about the 4 to 6 weeks is what I think is ideal, it seems, for them. There are some cases if we're trying to move things along faster that we might see them a little bit more frequently and overlap it. But that's more a time-based type thing, not necessarily a long healing. So if somebody says, like, time is of the essence, I gotta get better no matter what, athletes or that kind of thing.
Yeah, it's true.
Sometimes we might seem a little bit closer, but we're overlapping the healing phase.
Yeah.
So ultimately they might end up getting more treatments than they would have needed for the full healing.
Yeah.
But they'll get done faster with it. So it all depends on those factors there.
Like, say somebody says to you, they want to get prolotherapy, but they're afraid of needles. Like, how do you handle that? Like, do you ever numb it, or do you give them meds, or do you just...
There's numbing things. Sometimes some light sedation type things can be used. Yes,
like
we
what?
Do. So usually more like a Xanax type thing. So it's something that would keep them from
like a medicine
try themselves.
or
a medicine of some type.
We
don't do a true conscious sedation IV medications there at the university right now. I don't know, but there are several different things that can be used like that, depending on the case. I mean, I sometimes treat pediatric cases too. So, if I'm treating something like our pediatric specialist would send them to me because we have instability issues. So
explain a case.
Well, so like if I have somebody who is a hypermobility patient who is like 10 years old, we would deal with that patient very differently than the same hypermobility case who's 20 years old with it there. So usually that means taking more time, doing fewer injections, being very specific with it, doing more of numbing of the skin and other things like that. That won't completely remove the pain, but the case may take longer to treat for it, but we're just a lot more, if you will, gentle with those, as opposed to others. We'd say, look, if we do this fast, it gets done, and then we put a heating pad on whenever the line of cocaine is taking effect. It's happening that way. So
what's the youngest patient you've treated?
7, I think, for an ankle sprain.
No, it's just, I mean, people don't realize, like...
very gentle with those there, but still, that's the case. But I have others, usually in mid-teenagers, that kind of thing.
Do you feel like the kids heal quicker, like it's less visits? Because
they're
growing?
Yeah, for several reasons, but they usually heal much faster, and it would be like, 1 or 2 treatments for the average one that I see,
the patients I see, the dizziness, the vertigo, the this or that, are you starting to get more patients, like, that are inquiring that have, like, the neurologic symptoms?
Yeah, but not inquiring because of them. So it's still most of the patients that we see are because of the musculoskeletal related, if you're talking like neck pain, headache type ones with it. But especially the hypermobility ones will often have the dysautonomia associated. So we talk through those things, but it's not the main reason why.
But that's a good reason why you're here, because I'm sure you'll learn a lot about the physiology of it.
And because the physiology of treating the vagus nerve, that's a big thing in the osteopathic manipulation world anyway. So we're already attuned to that problem and all the different aspects the vagus nerve is doing. It's just trying to integrate it then into the prolotherapy world or integrating prolotherapy into that treatment as opposed to just the treatment of the OA joints, that kind of thing, from manipulation.
You've been doing prolotherapy for how long?
Since, let's see, I guess since 2009 or 10.
Okay, so let's say
because as soon as
almost 15 years. So let's just say 14, 15 years. Would you say that you're more convinced than ever that prolotherapy works?
Oh, definitely. Because even though that's when I started doing it as a physician, I've been doing it assisting it, with you or others.
Yeah, since you were
the
10 or
mid
something.
'90s, whatever.
Yeah, since you were 10 or something.
So I have experience of those. Yeah, there's no question, and it's neat to see more and more the things we can improve and get patients back from problems. Yeah.
Well, you're ready to head.
And I've been a patient myself too.
Yes.
I've had a number.
Well,
of
why
different
don't you explain what things have you?
Most of my injuries have been bicycle-related injuries.
Yeah, like what?
I've had knee and low back and neck and elbow and rib cage and thoracic spine. I think. Yeah. Ankle sprain also. I think. Yeah.
And it worked.
Worked very well for me. Yeah, because having my head kind of cranked down in that tight position for aero riding, and then a couple of the bike accidents where I hit the ground going kind of hard. Definitely caused some neck problems, but prolotherapy worked well for that for me.
Are you pretty much pain free now?
Yeah.
Like you feel good?
Yeah, from the areas that have been treated. Yeah.
Okay.
Definitely.
Okay. That's good. Well, you ready to have some fun? Go out to dinner?
Sounds good. Yeah.
Okay.
This has been fun though.
Yeah. Thanks for chatting. Thanks for reminiscing and
yeah.